My special guests today are Associate Professor Jeremy Millar, who is Director of Alfred Health Radiation Oncology, and Associate Professor Sue Evans, who is Head of the Clinical Registry Unit here at Monash University. Thanks both for your time.
Thank you.
You two are co-authors on a really nice piece of research that's going in our 2nd of May issue on quality of care on prostate cancer and the prostate cancer registry. Tell me a little bit about...
Okay, so we have a population-based prostate cancer registry which essentially accrues all men who are diagnosed with prostate cancer in our Crown hospitals, which make up 75% of the state now.
Yep.
And that means we can generalise our results to the whole state. So when we see things, we can say, well, that probably applies everywhere. And we gathered data about the men with prostate cancer and about the disease they have and about the outcomes.
Yep.
And one of the important things about looking after any problem like prostate cancer is to try and ensure it's high quality. And so we went through a process of defining quality indices, and Sue can talk a bit about that later on perhaps.
Yep.
And then we have followed those indices over time and recorded the changes, and our paper describes the way in which we think these have improved over time, and we think it's improved partially because of the work of the prostate cancer registry.
Sue, what were the 3 indices you used?
So the first one related to compliance with the PREIS protocol, and the PREIS protocol really looks at appropriateness of treatment for men with low risk disease. Increasingly there's evidence that men with low risk disease could be on active surveillance rather than having surgery.
Yep.
And so we were looking at the percentage of men who met the PREIS criteria for being on low risk, having low risk disease and being on active surveillance to see whether they were in fact on active surveillance or having treatment.
Right.
And we found that over the period of time that we were studying, from 2009 to 2013, that we saw a reduction in the number of men on active surveillance having treatment. So that was a really good outcome.
Yeah.
In fact, it went from in 2010 at 55% down to 34% in 2013, which was quite significant.
Does that indicate a level of awareness and education happening amongst patients or amongst clinicians, or...?
We don't really know whether it's amongst clinicians, hospitals or patients, but we do certainly know that this reduction, means that men are now less likely to have surgery if they've got low risk disease in these hospitals that we're studying. So understanding that a bit more is important, and there's certainly been more and more in the literature around the over-treatment or treatment for men with low risk disease, and I think that increased awareness is in part literature, in part just at conferences, and perhaps the feedback of the reports that we're giving to the hospitals every 6 months might also be increasing that awareness.
What was the second index?
So the next one we were looking at are the percentage of men in high risk groups who have treatment in the first 12 months. So obviously it's best if men in high risk for disease progression get treatment in a timely manner. That's important. And we saw that went from 88% in 2009 to 93% in 2013, so that's good also. Wasn't statistically significant, but certainly the trend is in the right direction for that.
Yeah.
And the last indicator that we were looking at in this paper, which was really our process of care indicators, is the positive surgical margin rates in men with PT2 disease.
Okay.
So,
Positive surgical margin is when a histopathologist looks at the prostatectomy specimen under the microscope.
Yep.
He or she sees cancer at the margin of the section, so there's cancer abutting the cut edge, and that implies that there's disease, cancer being left behind.
Right.
And furthermore, we know that under those circumstances, about half of the men with that situation will have a recurrence of the cancer.
Right.
And
So you want that number to go down, definitely.
You want that number to go down. And furthermore, there's good indication. There's 3 randomised controlled trials that show that if you're in a situation where you have a positive surgical margin, if you have immediate radiation treatment, the rate of recurrence halves.
Right.
But the problem with that, of course, is that you've got to have additional treatment and the side effects associated with the treatment. And so it'd be good if the positive surgical margin rate went down, because it would spare men additional treatment for their cancer.
Okay. And what did you find? The PSM rate went down, yeah?
Exactly. So the positive surgical margin rate was, in the mid to high 20% at the start of the period, and at the end of the period it dropped down to 12%.
Okay.
And that was easily statistically significant.
So it sounds like everything's good. We're doing everything right that we should be doing for prostate cancer treatment.
No, it shows that things are improving.
There you go.
So we're not doing everything right. There's more work to be done by groups like ours, and more resources should be expended on groups like ours to improve things even more for men with prostate cancer.
What areas particularly would you like to see improve further?
Well, we'd like to get total population coverage of
Yeah.
the registry for a start. As Jeremy mentioned, we've got 75% of the state, so we'd like to see that capture out to 100%, so we can really report, treatment across all men.
I think the other thing is that we want to extend out within the state, and we need to have engagement with the localities that aren't involved at the moment. But we at Monash have the ability to do the centralised back-end work, and we hope that there'll be a change in the culture and the attitude of health services, so that they start to do more of the front end of this data collection themselves, and then Monash, or groups like Monash, can look after the security of the data and the analysis of the data and reporting of the data.
Yeah.
And we can all work together to improve the outcome by getting full coverage. Going beyond Victoria, of course, we are now part of a initiative led by Sue and others to extend this across Australia and in fact New Zealand. So we hope to now try and cover the entirety of the continent of Australia and that bit on the side, New Zealand. An essential component of the registry is that not that we write about this in prestigious and well-respected journal like the Medical Journal of Australia. We talk about it and we report it back to the clinicians who are looking after patients.
Yeah.
And so we've got we hope a short and local feedback loop to tell them how they're going. And we think that mechanism of the contact between an independent, neutral registry and the doctors who are looking after the patients is part of the thing that's driving these changes. And so our hope is that we can extend this across Australia and get the same thing happening in everywhere in Australia. And the trick, I think, is that we're trying to get local engagement everywhere, local involvement everywhere. It wouldn't work if it was just Sue and some radiation oncologists from Monash telling people in Western Australia that they're not doing things right. We need to provide the data so that they can look at the data and conclude themselves they're not doing things right, and then talk about how to improve it.
Thanks so much for your time.
Thanks.
Thank you.